It is next my honor is to introduce our keynote speaker for today, Ryan Malosh, who is the director of the Division of Immunizations at Michigan Department of Health and Human Services. Ryan has over 15 years of experience in the conduct and analysis of epidemiological field studies of influenza and other respiratory virus infections. His interest in public health was sparked by a summer internship at a federally qualified health center in Traverse City, which is in northern Michigan, one of the most beautiful places in the world, most beautiful beaches in the world, right near Traverse City, if you haven't been up there. He then earned degrees in epidemiology from Boston University and the University of Michigan, and joined the faculty of the University of Michigan School of Public Health, where his research focused on respiratory virus transmission and prevention, including studies of vaccine hesitancy, vaccine effectiveness, and the social determinants of infectious diseases. In July 2021, he joined the COVID-19 response at the State Department of Health. He then transitioned to the Division of Immunizations in November 2021 to oversee the epidemiology section. In June 2023, he assumed the role of Director of the Division of Immunizations. His work currently focuses on improving immunization data quality and evaluation to drive public health decision-making and increase equitable access to vaccines throughout Michigan, with the ultimate goal of reducing the burden of vaccine-preventable diseases across the state. And we were just talking about an ongoing measles epidemic, and it is one of these things that we would like to not have to be using our resources in, and hopefully he's going to tell us steps we can make in that direction. Ryan, thank you so much for speaking to us today. Do you have slides?
I do have some slides, yes. Let's see here. All right, so does the clicker work? The clicker does work. All right, so today I thought we'd talk a little bit about like rethinking and the way that we've reframed our thinking at the State Health Department about disparities in infectious disease outcomes in light of the COVID-19 pandemic. So some of the main questions that we've been asking really are like, what have Michigan public health data systems even done around race, ethnicity, around measuring disparities? And then I think the big question for us is how good is that data quality, right? Like that's always going to be our concern with large surveillance data sets, that typically the data quality is, you know, subpar might not be the right word, but it's pretty close. I see Helen smirking back there. She knows. But kind of as we get our handle around those types of questions and the answers to those types of questions, where are the disparities in immunization coverage in Michigan? What are we, which diseases are there disparities? Can we see disparities for? You know, is it kind of more along these like one-off things like COVID, more seasonal vaccines like flu? Mpox was another, you know, one-off kind of issue, but what about routine immunizations? What are, you know, our childhood immunizations, the things that have been sort of like the foundation of public health and infectious disease prevention over the last 50, 60, 70 years. How are we thinking about those and disparities in those interventions? And then what have we done to try to address these disparities? And has it been effective? And then where do we go next, and how can you all help us do that? Okay, so let me give you a little bit of background about some of our data systems at the state, and I'm going to focus on, I'm the director of the Division of Immunizations, so I'm going to focus on our immunization information system. It's called MICR. It stands for the Michigan Care Improvement Registry. Although, that acronym is changing, and originally it was called the Michigan Childhood Immunization Registry, because as it started in 1998, it was focused on childhood immunizations. At this time in Michigan, we had the third lowest routine immunization coverage in the entire country. And the idea was, it was actually pushed forward by the governor at the time and his wife, that we could, if we knew more about, where people were getting vaccinated and helped providers really understand who is due for a vaccination, that we could improve those rates. And it did. We actually, over the course of like the first 10 years or so of MICR, we actually improved to be in the top 10 in terms of immunization coverage that's in the state. So that's, it was a really successful program. And because of that success, in 2006, it expanded to a lifespan registry. So it started to include all adults. I will say that what we are currently seeing right now is there's a legal requirement to report all childhood immunizations to MICR. So anybody actually under the age of 20, and that's because of some of the requirements of the Vaccines for Children Entitlement Program. But anybody under the age of 20, it is required that providers, any immunization that's administered to those folks is required to be reported to MICR. For adults, that's not the case. It's kind of voluntary, except for COVID, right? So COVID was federally reported. COVID vaccinations were federally required to be reported to immunization registries. And so we have a lot of data for adults now in MICR. I mean, it really exploded over the last 5 years. We are up to 13 million individual records in MICR of individual persons. And there's only 10 million people that live in the state. So we have a little bit of denominator inflation, but we also, we have some data quality stuff that we have to clean up. But we have over 200 million immunizations in our database. And we currently have over 7,200 active provider sites, many of those that joined during the pandemic as well. In 2005, so just before we expanded to a life course registry, MICR actually started ingesting electronic birth certificate data from our vital records division at the state. And so what that means is that we have really good denominator data for people who were born after 2005, right? We know pretty well whether or not somebody was born in the state. And then because we have these other connections with the vital records team, we know if they've passed away. We have a lot of other data connections statewide that allow us to understand if they've moved out of state, if they have, I guess really those are the kind of the two big ones, if they've died or if they've moved out of state. We're working on cleaning up some of our other systems, and because of the investment of COVID, we're able to work with places like LexisNexis to understand, if they have their Medicaid status has changed and things like that. Okay, so what are we doing about race ethnicity data in MICR? And this is kind of one of those things that is a little bit embarrassing, I think, for the state health department. We haven't done much, really. If you look at the dates here, you can see we started in 1998. We started getting that vital records data in 2005, and that included mother's race, which was how we were classifying folks based on their race ethnicity, basically until the pandemic. We had a couple of other data points here where things on our timeline here where we started to evaluate, some trends in routine vaccine coverage by race ethnicity, but it was really focused on that mother's race. Really incomplete, really, poor race ethnicity data that we were using. Now, COVID comes around and the federal government says we need you to report all of the race ethnicity data. And so we started doing more. So in 2021, we updated MICR so that we could ingest data from a medical record. So, a lot of this data is collected at the provider level, and it's sent to us via a data message. It's called an HL7 message. It's just a way that the EHRs talk to our immunization registry. But we started ingesting data from that. But we were still focused on that mother's race. And we were only collecting OMB standards. We were only collecting, very crude race categories. In 2022, we realized that there was probably some other places where we were missing folks and a true classification of their experience with, systemic racism and things like that. So we started expanding to the number of codes that we would accept, and included Middle Eastern and North African. And we also expanded our available language preferences so people could tell us actually what was their preferred language. We could think about then what that means for, for where they're coming from and what kind of experiences they might have had, including whether or not they, were born in the US and whether or not they received routine immunizations in childhood that are offered to all US citizens compared to what we see overseas. 2023, we added more race values, including our Michigan located federally and recognized tribes. And then we started validating these. So what we saw during the pandemic, and I'll jump ahead a slide here, is that we had a lot of missing data, right? So 25% of our COVID vaccines had unreported race ethnicity. And so we decided that we were going to start letting people know this. So if you send us a message with some immunization data and it's missing the race field or it's incomplete or not filled in, we're not going to send you a message back and say, hey, that was an error. You really need to include this data. So that's something that we rolled out in the last year. We're actually working on potentially, this is something that we have to do a lot of communication with our providers around, rejecting that data outright. So saying that this will not be, you actually won't be submitted. And because it's a legal requirement to submit childhood immunizations to the state registry, we have some levers that we can pull in terms of getting people to actually report these data. So this figure on the right here is actually looking at the providers, each of the provider sites in Michigan, those 7,200 providers that are reporting to MICR, the proportion of their immunization, the proportion of their shot data, so of the actual vaccination data that are missing race ethnicity. And the box here is showing us that most providers are actually reporting a high level, right? There's 75%, most providers are reporting 75% or more of their race data, but we've got a lot of outliers here, folks that are reporting, almost none, way up here at the top. And across the bottom here is the size of the providers. So we do have some really, really big ones. Those are probably going to be things like, if they've reported over 20,000 shots, that's probably going to be things like the mass vaccination clinics and things that we see at Ford Field during the COVID pandemic and those kinds of places. But it's kind of hard to discern much in the way of a pattern here for provider types. But one of the things that we have seen is these other providers, so non-standard, non-traditional immunization providers, are less likely to report complete race data. So that looks like things like visiting nurses and places like that. But we've got a lot of work to do to outreach to those folks so that we can make sure that we're getting all of that data and that they understand that they're going to have to do this in the coming year. I guess the next question I wanted to ask is like, why have we been ignoring race so much at the state level? And I think it's kind of illustrative to think about like what kind of messages we were seeing at the beginning of the pandemic, right? So this top quote here, the doctor who helped defeat smallpox explains what's coming. This is a headline from Wired magazine where they did an interview with Larry Brilliant. And he actually uses this term, which I think is extremely damaging. And Grace and John and Helen will know that I have been railing against this phrase for a long time. He says the virus is an equal opportunity infector, right? That's obviously not true. And there's no such thing. But that is a real misconception that we had about a lot of respiratory virus infections. Going back, half a century or more, we've thought that because in a lab, because in a petri dish, the virus infects people's cells at the same rate, that people were exposed at the same rate, or that they were more as likely to become infected as anybody else. Now that's really something that was proven incorrect in a really dramatic fashion by the COVID pandemic. But that wasn't the only person who said that. Jonathan Van Tam, who's a really well-respected infectious disease epidemiologist, also said the virus doesn't care what ethnic background you're from. It doesn't care about the color of your skin. And the virus might not, but the systems that we have in place actually really do, right? So, this is data from a study that I worked on with John Zellner at the University of Michigan School of Public Health, showing that there are extremely large disparities in the infection risk for Black Michiganders compared to white Michiganders. And that's true for Asian and Pacific Islanders and for Latino Michiganders as well. And this is from really early in the pandemic. So this is like the first 9 months of the pandemic that we looked at these data. And I think it's really important to note that at this point, there are no vaccines. The treatment options are very limited. And the risks of severe disease because of things like uncontrolled diabetes or other high-risk comorbidities or some of these other things are not really well understood. And the people who are bearing the burden at the beginning of this are the more marginalized groups, right? Those that have less access to resources. They also tend to be working in positions where they're unlikely to be able to stay home from work or work remotely or social distance or, adopt other non-pharmaceutical interventions. And so really it's kind of like a double whammy for these folks. This figure then is looking at similar data, but the left-hand side here is the cases, and the right-hand side is the case fatality rate. So what it's showing is that there's not all that much difference, especially at older ages, in the case fatality rate. But really the disparities here, because we saw such larger numbers of folks, of Black folks, of Latino folks in Michigan dying of COVID early in the pandemic. It's really driven by these cases, the incidence of cases, and not by the fact that they're more likely to have severe outcomes. It's that they're more likely to get infected and therefore have a severe outcome. So there's a whole chain of events here that is happening that was kind of ignored and not really thought about. We knew that things like HIV, TB, malaria are diseases that have social determinants, but the fact that this is it took studies like this to show that for a respiratory virus infection, even though, I think most people who were paying attention would have realized that before, was really, really dramatic, and explains why we didn't really think about these things at the state public health level prior to the COVID pandemic. So what are we doing now? We are documenting a lot of disparities in a variety of immunizations at the state level. So we have publicly available dashboards that report on the number of vaccines administered, the coverage by geography and by demographics. And this figure is showing the coverage for COVID-19 vaccine for all ages. And the black bars here are going to be at least one dose. So they've received at least one dose of vaccine. The blue bars are going to be the most recent updated 2024 vaccine. So you can see, I think the big takeaway from this is, wow, we really have very little interest in people in vaccination at the state level. And most of this is driven by the fact that kids and young adults have basically chosen not to be vaccinated. And I'll show another slide in a minute that'll maybe highlight that a little bit better. But we do see throughout the pandemic that there are some clear disparities by race, ethnicity. So, Black Michiganders are only 46% have received at least one dose, compared to 56% of white Michiganders, and 75% of Asians. So there are very clear patterns here. It's that holds also for the updated vaccine. So only less than 8% of Black Michiganders have received the updated vaccine. Similarly, less than 8% of Hispanic Michiganders have, and close to 13% of white Michiganders have received the updated vaccine. So we really are continuing to see this disparity. It's been really consistent over time. And it's something that speaks a lot to trust in institutions and things like that. But it's been really consistent. If you look at 65 plus, so these are the people who are most likely to have a severe outcome from COVID-19, right? So these are the people that we really, really, really need to be vaccinated so that we can keep them out of the hospital, the hospitals don't get overwhelmed, and so that we can reduce the burden of mortality and things like that from COVID. We do really well here, right? So like 95%, 95%, 96.5%. I mean, those numbers are quite a bit more dramatically better than what we were seeing before. And it's true for the updated vaccines too. We're closer to 35%. And actually there's a little bit less disparity here in the 65 plus. I mean, we still see that Black Michiganders are less likely to be vaccinated, but it's not quite as dramatic as it was for all ages. So it really does speak to the fact that there's been some effective communication around who is at risk of severe outcomes from this. And we were able to address that just a little bit. Race ethnicity isn't the only way that we can look at disparities, obviously. We tend to focus a lot on geographic variation. And so thinking about things like rural counties versus urban counties, you can see here the orange and the red colors mean lower coverage. The blues and the greens are higher vaccine coverage. And for at least one dose, there's a lot less of that dark red. So, higher coverage overall. And there's more of a mix, I would say, right? So we can see that there's some rural counties in the UP that did pretty well. This little peninsula here, the Leelanau Peninsula, did very well and has consistently done pretty well with vaccine coverage. But a very well-to-do county there, a lot of high-income folks that live in that county. And then I'll just point out a couple of things here. It looks like there's some spots along the southern border of Michigan that look like they're pretty low coverage. That's probably a data quality issue. A lot of those folks pop over to Wisconsin or to Indiana or to Ohio to get vaccinations, and those aren't necessarily reported into our immunization registry. We're working on building those connections now. We've got one with Wisconsin. We're working on others with other states so that we can get more complete information and try to understand really the geographic variation in vaccine coverage a little bit better. Okay, so moving past COVID, what else are we doing around disparities? When Mpox hit in Michigan, it affected Black Michiganders at a much higher rate than it did anybody else. So this is looking at, on the left-hand side here, the green bars are looking at the proportion of all Mpox cases that belong to a certain race or ethnicity. And then on the right-hand side, the purple bars are looking at the proportion of all vaccines that were administered. So Jynneos vaccines that were administered, and that proportion by race ethnicity. And you can see that there's this really stark difference where the cases were primarily in Black Michiganders, but the vaccinations were primarily in white Michiganders. And so this is something that we were trying to, despite the fact that we, at the state immunization program, we put a lot of our resources into making vaccines available to Black Michiganders. We had more clinics in Detroit and in Pontiac and in places where we have a high proportion of Black folks living in the state. We put all of our resources into getting vaccine into that area. We still didn't have high uptake there. We had people coming from the suburbs to come down to Detroit to get their vaccines, which was disappointing for us and a bit of a challenge, and something that we have to figure out more. It's not just putting vaccines into a certain spot. How do we reach the populations that we actually need to protect? In terms of routine immunization, so this 4313314, this is the vaccine series that we look at most commonly for children 19 to 36 months old. CDC tracks on this a lot. We use this as kind of a general marker of vaccine uptake. And you can see similar story, same song, different verse. Black Michiganders are less likely to be vaccinated than white Michiganders. But also we have a big unknown group here as well, because we aren't capturing race, ethnicity as much as we should. But then what about other non-racial disparities? So we have been focused a lot on our Medicaid population, and that's because of this giant disparity that we saw during the COVID pandemic, right? So the blue line here is Medicaid eligible kids. The orange line is non-Medicaid eligible kids. And so during the pandemic, pre-pandemic, we saw that Medicaid kids were vaccinated at a higher rate than non-Medicaid eligible kids. And that's mostly because we have things like the Vaccines for Children program, which specifically targets those kids and gives them free access to immunizations. There's kind of a convergence in the middle of this graph here. And then during the pandemic, there was this really yawning disparity where the Medicaid kids fell off at a much higher or much faster rate from their pre-pandemic coverage levels than the non-Medicaid eligible kids did. Unfortunately, these two did converge again, but in the wrong way. Our non-Medicaid kids dropped dramatically sort of after the acute emergency phase of the pandemic. And then there's kind of been some back and forth now. Both are starting to trend back up, which is a good sign. But we are still concerned about the fact that our Medicaid population was really underserved in this part of the pandemic. And how do we catch those kids back up? How do we make sure that they're on the right track? Oh boy, 5 minutes left. Okay. So why do subpopulations matter? If you look at these, this is a map of MMR coverage at the county level and then at the sub-county level, so the census tract level. And you can see if you look at this purple county here, that's Oscoda County, and they've had a dramatic decrease in coverage over the last 5 years. But it's really driven by this one census tract in the middle of the county. And what is it about that county that is, or about that census tract that's important? It actually tends to be a high population of Amish folks that live there, and they are not attending schools in the traditional way, and they're not required to get vaccinated before they enter school. So there's a lot of work to do to understand why there's an area of a county that might be under vaccinated, and what do we do about that to prevent outbreaks. We wanted to think a little bit about also about like what does thinking of these subpopulations, is it an access to care issue, right? Like that's kind of the thing that we always think about is that maybe there's just not opportunities to get vaccinated for these kids. This is actually work that we did for COVID vaccine. We looked at census tracts with both high SBI and low vaccination coverage. And then we sorted those by the number of individuals that were unvaccinated in each place to sort of maximize our impact. And then we picked some rural and some metro areas. And I'm going to use this to illustrate like why our data systems are maybe not as good as what they could be. So we identified this census tract in Flint, southwest Flint, that had both of those things, very low coverage and very high SVI. And then we looked and we mapped all of our COVID providers and found that there were 14 COVID-19 providers within a 5-minute drive time of that census tract. So like, you know, that's kind of middle of the state, middle of the road from what we have seen across the state. It's not great, but it's not terrible. There are options there. But we took that data to the local health department to try to understand more about the context. And what we learned was that there was actually a large apartment complex in that census tract that closed during the pandemic. And about 50% of the population of that census tract had moved. They left that census tract completely. So our denominators were skewed. Our coverage estimates were way too low. And by working with that LHD, we were able to identify other locations that had low coverage and high SBI, but also had few providers. And then we could try to figure out where are some alternative providers that we can bring into that area to get people vaccinated. But ultimately, by the time that we had figured this out, you know, it takes time to run these analyses, to schedule time to talk to the local health department who is overburdened and understaffed, and to have that conversation with them and try to figure out what's going on. There was no demand for vaccine anymore. So people had moved on. They were tired of being told that they had to be vaccinated, and we weren't able to ultimately improve rates. So the challenge here, you know, this is really the hard part. So we don't have enough time to come up with answers, but hopefully by thinking about some of these things, we can maybe come up with a way forward. So you know, really want to think about like a fundamental cause approach. So how do things like racism and socioeconomic status affect multiple pathways? So that you know racism leads through either racial segregation that can change your vulnerability or your care access, but it can also mean that you're more likely to work in a job where you can't stay home during a really acute epidemic, and then you're more likely to be exposed, you're more likely to be infected, and then you enter this pathway where you end up at severe disease, hospitalization, and death. So how do all these things work together? How do we find a way to measure this and incorporate it into a state public health system? Also, I want to point out the fact that like race is not really what we care about here. We measure race and ethnicity because that's what we have available to us. But racial definitions are often not reflective of sociocultural factors. They don't capture the intersectionality that we know is important. They often exclude large subpopulations like we were doing early on, where we didn't have North African and Arab Americans included in Michigan, which are a large subpopulation that we're interested in. And I think really the challenge here is going to be moving beyond just like these reductive analyses and looking at a dashboard that shows demographics or aggregate non-actionable place-based metrics like SVI, and really move beyond documenting those to understanding the causes of those disparities, and then how do we address those? How do we work as a state public health system with our Medicaid partners. What policy levers do we pull to actually make a difference here, and what data can we use to help inform our resource allocation and drive decisions in an effective way? I put this one really big because I think this is the biggest thing that I think about right now is what can we do to rebuild trust? We know it's been negatively impacted by the pandemic, and a part of that is our own fault, and some of the confusing messaging that we've put out. But how do we build partnerships with local public health, with community-based organizations, with you all, with payers, with health systems to understand understand context like we did with the Genesee County data, or to capture data that is actionable. And then what do we do to redefine what access means? You know, access to vaccines is not just having a provider in your area. Are they scheduling their appointments online and you don't have broadband access? Do they not have after hours appointments and you work 9 to 5 or you work 3 different jobs? How are we making sure that vaccines are accessible, convenient, and desirable? And that's really how I think what we have to do to move forward. So thank you for your time, and take thoughts and questions.